without using any muscle relaxants. A few years later, Linda Van Mater and colleagues did a case cohort study to evaluate the relationship between NICU practices and occurrence of BPD in infants weighing 500 to 1500 grams at 3 major neonatal ICUs, Columbia, and 2 in Boston, Beth Israel Hospital and Brigham and Women's Hospital, and they defined oxygen need at 36 weeks postmenstrual age. As you can see in the data, they reported a 5 to 6 times higher incidence of BPD in Boston NICUs compared to Columbia. And when they compared the care practices between the two groups, Columbia utilized higher CPAP, lower ventilation, and when they used ventilation, they used it for a shorter duration. The use of surfactant, indomethacin, and sedation was also lower at Columbia, and there were no significant differences in other morbidities such as IVH, PVL, NEC, or ROP. So with that epidemiological background and some prospective data, I'd like to share with you some of the physiological effects of CPAP. So what are the acute effects of CPAP on ventilation? It was nicely demonstrated by Zhang and colleagues, who showed that as the airway pressure increased from 0 to 6 centimeters, the end expiratory volume and tidal volume increased immediately and the breathing frequency decreased without affecting the minute ventilation. In the same animals, the authors showed that prolonged use of CPAP resulted in incremental increase in the total lung capacity. At 2 weeks, the lung capacity was 40% more than the baseline capacity. Further, this change in the lung capacity was due to increase in lung volume, lung weight, and the total amount of lung protein and DNA content. So it was not just distension of the lung, there was an overall growth of the lung. How about the effects of CPAP on lung recoil? So shown here are group deflation static pressure volume curves in excised air or saline-filled lung in control animals and animals on CPAP for 2 weeks. Open circles and rectangles represent the air-filled lung, and the solid black circles and rectangles represent the saline-filled lung. As you can see, there was no significant effect of CPAP on lung recoil in either air or saline-filled lungs. So this preservation of volume-corrected lung recoil in CPAP-exposed animals suggests that this response does not involve a mere simple lung distension, but includes remodeling of the lung parenchyma. So this all makes sense, but is the use of CPAP as an initial treatment for preterm RDS evidence-based? This was a difficult question to ask in the past, but if you ask me today, the current clinical evidence, my answer is yes, yes, and yes. And why do I say that? If you look at the recent randomized controlled trials of CPAP for early respiratory support in preterm infants done over the past decade, they all support the use of CPAP. If you look at the Colin Morley's trial, COIN trial, which compared early CPAP with conventional early intubation, ventilation, and rescue surfactant, or the US support trial, which compared early CPAP with intubation, surfactant, and brief ventilation, followed by rapid extubation, the INSURE technique, or the WAN trial, which had 3 arms: CPAP arm, the conventional ventilation with intubation arm with prophylactic surfactant, and the INSURE technique. The South American trial compared early CPAP with oxyhood with rescue surfactant in both groups if the oxygen requirement exceeded 35%. And lastly, the European trial, CPAP trial, which compared early CPAP with INSURE. If you summarize all the data and look at the primary outcome, which was the death of BPD, though not statistically significant, infants in the CPAP arm had a modest reduction in composite outcome of death or BPD across all trials, with a mean incidence of 29.2% in the CPAP arm and 33.5% in the intubation arm with surfactant. Importantly, there were no differences in the incidence of air leaks between the treatment arm, which was 5.7%, and intubation surfactant arm, which was 6.2%. So the question I may, or why that's good, CPAP seems to be doing at least as good as intubation and surfactant. Why didn't we see that much effect of CPAP in these trials? And there are several potential reasons. I think most importantly, there were the people who were in these trials, their relative experience with CPAP was not as good. Their greater skill with other forms of respiratory support. The thresholds for abandoning CPAPs were too low, and they used CPAP for much shorter durations. If you read these trials, CPAP delivery systems were used, and some of the delivery systems may be more effective than the others. So there were reasons that CPAP results were not as good as they could have been. If that was the case, we would have gotten clinical or statistical significance too. Success with CPAP does not happen overnight. There is a learning curve to the success with CPAP. This was very nicely demonstrated by Hani Ali, who trained at Columbia many years ago, and then he moved to Washington, D.C. And after implementing early CPAP in 1997, he reported chronological data for the ensuing 4 years, and he clearly showed that during these 4 years, as the use of early CPAP increased, CPAP failure almost became half, the use of surfactant decreased, and he was able to decrease the incidence of BPD threefold. And he continues to do well, and his numbers are almost similar to what we have at Columbia. So based on what I have talked about, I can conclude that the initial stabilization on nasal CPAP and provision of rescue surfactant only when it's necessary is at least as beneficial and quite possibly preferred over the standard therapy of intubating all infants at risk in the delivery room and subsequent support with mechanical ventilation. In fact, the Committee of Fetus and Newborn in the most recent policy statement on surfactant replacement therapy for preterm neonates published in 2014 have stated, and I'm going to read this verbatim, using CPAP immediately after birth with subsequent selective surfactant administration should be considered as an alternative to routine intubation with prophylactic surfactant or early surfactant administration in preterm infants, level of evidence category 1, all from randomized controlled trials. Further, preterm infants treated with early CPAP alone are not at increased risk for adverse outcomes if treatment with surfactant is delayed or not given. Again, level of evidence category 1. So moving gears, we are all aware of the physiological effects of CPAP. CPAP increases transpulmonary pressure and functional residual capacity. It prevents alveolar collapse, decreases intrapulmonary shunt, and improves lung compliance. CPAP also helps in conserving surfactant, prevents pharyngeal wall collapse, and stabilizes the chest wall. It increases airway diameter and splints the airway. That way it can be utilized well with airway diseases such as meconium aspiration syndrome. CPAP also splints the diaphragm. For me, more importantly, CPAP stimulates lung growth, as I've shown you earlier, and bubble CPAP has high frequency ventilation through the stochastic resonance. I'll talk about that later. Moving on to the desirable features and the major components of the CPAP system, there are 3 major components: heated and humidified circuit for continuous flow of inspired gases, the nasal interface to connect the CPAP circuit to the infant's airway, and then is the mode of CPAP generation. I'll briefly talk about each one of them. Some of the salient features of the setup: oxygen and compressed air sources provide inspired gases at desired inspired oxygen concentration, and the flow meter controls the rate of flow. The minimum flow rate should be sufficient enough to prevent rebreathing of CO2 and is usually 2.5 times the infant's minute ventilation. The flow should also compensate for leaks around the connector and the CPAP prongs, and usually a flow rate of 5 to 10 liters per minute is sufficient. When blended oxygen is not available, which could be the case in many of the developing world, one can use the separate oxygen and air flow meters, and then the oxygen airflow chart to figure out how to get the desired amount of oxygen. For example, to deliver 50% oxygen at 6-liter flow, all you need to do is use 3 liters of oxygen and 4 liters of air to get 50% oxygen. So it's very simple if you don't have blenders, which would be an issue. These inspired gases need to be warmed. They need to be humidified before they are delivered to the infant. This helps in avoiding the mucosal injury. Talking about the nasal interfaces to connect to the CPAP circuit, several interfaces are available. Various nasal prongs manufactured by Hudson, Baby Plus, Inca, Draeger, Fisher-Paykel, CPAP, Arabella, NeoPAP are available. Nasal masks and nasal cannula, vapotherm are also used. CPAP can also be delivered by nasopharyngeal tube and endotracheal tube. When you're trying to pick an interface, you have to ensure that the nasal prongs follow the contour of the nasal cavity, which is curved as shown in the figure up here. The nasal interface with the curved prongs shown at the top here is a much better fit than the straight prong interface at the bottom of the screen. So if you want to direct CPAP, you want to direct it to the nasal passages, not to the brain. There are several cannulas available, and just to share with you, the Hudson cannula, which we use at Columbia, they come in 6 sizes from 0 to 5, and the manufacturer has corresponding birth weights which match with the size of the cannula for the use. Similarly, the Baby Plus, which is also a curved cannula, they come in 8 sizes from 0 to 7. The advantage of this particular brand is they're made of silicone, so they're not PVC and they are latex free. We use the 2 extremes, size 7 and size 0 for very tiny babies at Columbia University. RAM cannula is being used increasingly to deliver CPAP due to its ease of use. If you look at the FDA approval, it was only approved for oxygen delivery as an oxygen delivery cannula and not as a pressure delivering cannula. If you look at the data on the mean airway pressure that is generated at various CPAP settings with 60 to 80% of occlusion as recommended by the manufacturer and a closed mouth, RAM cannula only delivers 60% less mean airway pressure compared to the short binasal cannula. Further, binasal cannula prongs offer less resistance. It's almost 3-fold less than the RAM cannula. If you look at the smallest RAM cannula size, commercially available as preterm, it has 400 times the higher resistance when compared with the short binasal cannula. What about the high flow nasal cannula? I think this data from Lavizzari and his colleagues very clearly demonstrate that the end expiratory pressure that is generated with using this cannula, it correlates very poorly with the flow. If you look at, for example, at the weight adjusted flow of 4 liters per minute, high flow nasal cannula pressure could vary from anywhere from 2 centimeters of water to 7 centimeters of water. I would be very skeptical of using high flow nasal cannula as a pressure delivering device. If you look at the data on electrical activity of diaphragm during CPAP use and high flow nasal cannula use, and it's very clear that the use of high flow nasal cannula is associated with increased diaphragmatic activation compared with nasal CPAP, and also the respiratory rate and cycle dynamics suggest that CPAP may provide more effective respiratory support than the high flow nasal cannula. A word of caution, there are safety concerns as subcutaneous emphysema, orbital air, and pneumocephalus have been reported with the use of high humidity, high flow nasal cannula. So now that I've spoken about the interface, I'm going to briefly talk about how to generate the pressure. So one can use a constant flow system, and the most simplest one is a water seal system that utilizes threshold resistor principles, where the pressure is determined by the force applied to the surface area and generated pressure is independent of the flow. Bubble CPAP systems such as Fisher-Paykel, Baby Plus, airway development, homemade systems are most commonly used. Another form of constant flow system is the flow opposition with a variable threshold resistor valve. This is what we do with the ventilator CPAP. Here the patient expiratory flow opposes a constant flow from the nasal prongs and generates the CPAP. In contrast, the variable flow system, there is a flow opposition with fluidic flow reversal during expiration, where the gas is entrained during inspiration to maintain stable pressures, and in expiration, the expiratory flow is diverted via a separate fluidic flip-flop valve. The Arabella generator and the infant flow driver are typical examples of this system. And to illustrate that further, in the variable flow infant flow driver, during inspiration, the flow is converted to pressure. It reduces the work of breathing and maximizes the pressure stability at the nasal interface. However, during expiration, the flow is flipped away from the nasal prongs to the expiratory tube. Thus, the residual gas pressure provided by the continuous gas flow creates a stable CPAP pressure during the whole respiratory cycle. It makes sense. However, limited randomized and non-randomized clinical studies in preterm infants comparing the infant flow nasal system and the simple single prong system have found no significant differences in short-term or long-term outcomes in physiological variables. So, having talked about the three components of the CPAP system, I'm going to move more towards creating a basis for benefits of bubble CPAP system as a preferred method to deliver positive airway pressure. This is illustrated very nicely by Jane Pillow and her group, who demonstrated that the bubble CPAP system enhances lung volume and gas exchange in preterms much better. What they did, they intubated preterm lambs of 133-day gestation. The term gestation in sheep is about 152 days, and then randomized them to bubble CPAP of 8 or 12 liters per minute flow or constant pressure CPAP via the ventilator circuit. And what they showed was the animals treated with bubble CPAP, shown here in solid rectangles, had enhanced ventilation by having a better pH and lower PCO2 compared to constant pressure CPAP, shown here in open circles. Further, bubble CPAP animals also demonstrated improved oxygenation and enhanced oxygen extraction compared to the constant pressure system. In their study, they were not able to show any differences between 8 or 12 liters flow. So what could be the reasons or physiological explanation for improved performance on bubble CPAP? I think the more efficient utilization of inspired oxygen in the bubble CPAP group is very suggestive of increased airway patency. The promotion of airway opening events likely explains the short-term improvement in respiratory physiology. Lung volume recruitment and surfactant secretion may be improved by superimposing the stochastic resonance effect from the variable pressure oscillation associated with water-sealed bubble CPAP on the underlying subthreshold biological breathing pattern. How about the effectiveness of bubble CPAP during the post-extubation period? Gupta and colleagues randomized 140 infants of 24 to 29 week gestation to infant flow driver CPAP or bubble CPAP in the post-extubation period. The primary outcome was successful extubation at least at 72 hours. And as you can see, the proportion of infants in both the groups who achieved successful extubation for 72 hours was very similar. However, if you look at the median duration of CPAP support in infants ventilated for less than 14 days, it was 50% shorter in infants which were on bubble CPAP. So bubble CPAP has the potential of being effective in the acute phase of the disease and also during when the babies are recovering and are being weaned off the respiratory support. So the next question is, are all bubble CPAP devices created same way? I think Poli and colleagues recently reported a study comparing volume oscillations delivered to a lung model using 4 different CPAP systems: the homemade system, the Fisher-Paykel system, the Bobby Plus system, and airway development system. And what they looked at was the magnitude of lung volume oscillations as a result of bias flow. You can see the Fisher-Paykel system, shown here in black, provided the greatest magnitude of lung volume oscillation than compared to any other devices at all of the bias flows. The magnitude of lung volume oscillation increased at bias flows above 4 in 3 systems: the Fisher-Paykel, the homemade, and the airway development. And in contrast, the Bobby Plus system, at flows higher than 4, there was a decrease in the oscillation. So one of the reasons is the airway development and Bobby Plus system utilize a diffuser in their bottle, and that diffuser attenuates the oscillations and decreases the interaction between the air and water. So it seems from their data, the Fisher-Paykel and the homemade system perform much better. In addition, if you look at flow rates over 8 liters per minute, the homemade and the Fisher-Paykel system generate second bandwidth frequencies at 54 to 76 hertz and 61 to 71 hertz respectively, that may promote enhanced lung recruitment, especially in an unhealthy lung. The airway development and Bobby Plus system don't do that. So what are my clinical recommendations? All spontaneously breathing preterm infants with respiratory distress syndrome weighing less than 1,500 grams should be allowed time to demonstrate if they can achieve acceptable ventilation and oxygenation with nasal CPAP. During this time, I put that in bold red, these infants must be closely monitored. If ventilation is not improving or oxygenation is worsening or inadequate with an FiO2 of more than 0.6, infants should be intubated and given surfactant. What about CPAP failure? This is a big concern when CPAP is used as a primary mode of respiratory support. In fact, Clyde Wright and his colleagues reported a very high incidence of CPAP failure at 5 to 7 days when CPAP was used as a primary mode of respiratory support in extremely low birth weight infants enrolled in major randomized controlled trials. We recently reported a 10-year practice trends between the years 2009 and 2018 at Columbia-like centers that practice gentle respiratory support strategy, which uses CPAP immediately after birth with selective ventilation and surfactant administration, shown here in blue, and we compared our data with the WAN. WAN is a network of more than 800 NICUs, and many of these are type C NICUs, so we compared this gentle strategy with the data from the type C. And you can see over this 10 recent years, the use of CPAP is much higher at Columbia-like centers and compared to the type C WAN centers. But interestingly, the use of CPAP is increasing at all these centers. The use of ventilation is much lower at Columbia, and it's slightly going down at other places. When you look at the treatment with surfactant, again, low at Columbia-like centers, and maybe a little dent in here. Postnatal steroids seem to be coming back. But when you look at the outcome, that is the incidence of oxygen use, whether you look at 28 days postnatal or 36 weeks post-menstrual age, it's still very high at these centers. And more babies are being discharged home on oxygen in WAN type C centers. The question now, which I have, is how come they're using CPAP much more, ventilating less, and still their BPD is not going down? So I think that brings me down, and especially after having established the basis for bubble CPAP, to the main crunch of this talk, which is the fine art of practicing bubble CPAP. I mentioned earlier, it doesn't happen overnight, and I would like to share some practical aspects of nasal CPAP application in the next 10-15 minutes and share with you some strategies for success. I refer to them as 10 pearls of bubble nasal CPAP success. First and the foremost, choosing the appropriate size of nasal prong. Choose the correct size of prong in order to provide effective nasal CPAP and avoid erosion of the nasal septum. Both Hudson and Bobby Plus have recommended prong sizes by weight. Other manufacturers also have recommendations for the individual prong size. The correct size of prongs should snugly fit into infant's nares without pinching the septum or causing any blanching. How should you fix the nasal interface? The circuit tubing can be fixed easily with a snugly fitting cap with rubber bands and Velcro, rubber bands and safety pins, or one can use Velcro. In bigger infants, curly bandage can help to maintain the shape of the head while the infant is on CPAP. And the bottom line is, when secure, the interface should move when the baby moves the head. So everything should move all together. Further, to secure the nasal interface, one can use a pre-cut single or a split Velcro mustache. This is the rough surface of the Velcro, which gets placed on the skin, and then the smooth part of the Velcro is placed on the nasal cannula as shown. And what you want to make sure is, after you put the prongs in the nostrils, then there should be a space between the nasal septum and the nasal cannula. That is the crucial thing, and I think that's one thing which keeps the incidence of septal injury very, very low or almost none at Columbia University. Tegaderm and Deoderm, thin Deoderm base, can assist in stabilizing the mustache and the cannula, particularly if the infant has a lot of secretions. Homemade seal or commercially available, if you have enough finances, cannulae can be used to obtain a good nasal seal. Mustache and nasal cannula, I will repeat this multiple times, should never touch the septum. When properly positioned, the corrugated tubing should not touch infant's skin. There should be no lateral pressure on the nasal septum, and a small space should always be present between the tip of the septum and the nasal cannula connecting the prongs. How can you optimize the CPAP delivery? A small neck roll goes a long way under the infant's neck to prevent neck flexion and airway obstruction. Chin straps, as shown here, or pacifiers can be applied as needed to maintain airway pressure. They can also decrease the leak from the gases, and they promote bubbling. Importantly, vigilant care is needed to ensure correct positioning of the CPAP prongs at all times to avoid septal irritation. The nasal cavities, oropharynx, and stomach should be gently suctioned every 3 to 4 hours as needed to improve ventilation and decrease abdominal distension. When you're performing nasal or oral suctioning, prior to removing the prongs, one should ensure to cover the eyes. This will prevent contaminations from nasal secretion. Infant's position should be changed every 3 hours. Infant can be placed prone, supine, or lateral. All positions are acceptable. But again, always ensure that there is no additional pressure on the nasal septum or the face from the tubing. It is essential to systematically check the CPAP delivery system multiple times during the day. The inspired gases should be well humidified with temperature around 37 degrees to prevent irritation of mucous membranes, avoid mucus plugging, and to mobilize the secretions. The condensed water in the tubing should be periodically drained as needed. One has to ensure that the distal end of the expiratory tube is always inserted to the appropriate length below the liquid surface in the bubbler so that you're generating the desired CPAP. The liquid in the bubbler can be either sterile water, or we use 20.25% acetic acid, which has the potential to decrease the risk for Pseudomonas infection. And we recommend that the nasal CPAP circuit should be changed at least once a week. One has to ensure that there is no gastric distension, for which a feeding tube should be placed to permit gastric venting and decompression. This decreases the excessive pressure from the diaphragm and improves the lung expansion. The tube should be suctioned every 3 hours if infant is not enterally fed, or before feeds if the infant is being fed, and we tend to check the tube position and patency every 12 hours. If infant is on CPAP, infant can be fed via nipple, gavage, or continuous feed. CPAP is not a contraindication for not feeding. Also, early parental involvement in nipple feeding while the infant is still on nasal CPAP, it facilitates the bonding for same reason, and skin-to-skin care is to be encouraged when infant is on nasal CPAP, as you see in the picture shown above. Coming to how to wean nasal CPAP, I'm going to share you the stability criteria for readiness of nasal CPAP when we wean at Columbia. For me, the best indicator is when the nurses, they give the bath at the night time, they leave me a message saying this baby is ready for coming off CPAP. But we have objective criteria. We wean CPAP only after infants are more than 30 weeks. They're not on any supplemental oxygen for at least 48 hours. They're completely asymptomatic with PDA, which could be there still. There are no apneic episodes. There's no suggestion of infection. There's no significant bradycardia or desaturation that require intervention. Less than 2 self-limiting bradycardia or desaturations in the past 12 hours are okay. And the oxygen saturation has to be more than 90% on room air. How do we wean? It has been done using 3 different approaches. You can completely take off CPAP when the infant is stable on room air without any respiratory distress. You can cycle, where the infant comes off for a period and then goes back, gradually increasing the time off and reducing the time on. And this way, infant can be completely weaned off. And the third method is switching to a nasal flow nasal cannula when the CPAP is off. But we don't know what pressures we are giving with this nasal cannula. Has this been evaluated? These methods have been evaluated nicely in a randomized controlled trial looking at all these 3 methods. And it was very clear that method 1, which is complete wean with intentions to stay off, it resulted in lower time to wean, lesser total number of days on CPAP, supplemental oxygen, lower incidence of BPD, and even the length of hospitalization was decreased, and infants were discharged at a much lower corrected gestational age. So if you're going to wean, we do the same. We wean infants off with intentions to keep the infants off once the infant Obviously, I'll talk about managing the failure in a minute, but another important aspect is avoiding the potential complications with CPAP use. These complications include nasal obstruction from secretion or improper application of nasal prongs, gastric distension from swallowing of excessive air, nasal septum erosion as shown here. This could be prevented by choosing the right size, vigilant care to keep the cannula off the nasal septum at all times. I've seen in some of the units they try to put something. This is absolute no-no. The small surface area, if you protect it over here, if even there is a little pressure, it's really going, because of its small nature, it's going to put a lot of pressure and there will be septum. So these two are definitely a no-no. How do you identify and manage nasal CPAP? CPAP failure can occur during the acute phase of RDS or during the recovery when nasal CPAP is being used to wean. CPAP prior to starting mechanical ventilation, it is important and imperative to ensure, number one, the blood gases are compatible with how the infant looks. Before you abandon CPAP, it is important to rule out the improper application of CPAP, poor fitting prongs, nasal obstruction due to secretion, airway obstruction from flexed neck, gastric distension, and too frequent handling of an unstable infant also doesn't help. If the CPAP system is felt to be working properly and oxygen is still inadequate, in select group of infants, they may benefit from increasing the end expiratory pressure to we use up to 8 millimeters of mercury. CPAP failure can occur immediately after weaning, coming off CPAP, or as late as 12 to 24 hours later. If the infant is experiencing frequent episodes of apnea, bradycardia, desaturation, or develops distress while off CPAP, the CPAP should be taken. If this happens while the baby is off, then the CPAP should be placed back again. So to summarize the use of CPAP, here are some take-home practice points. Use of nasal CPAP as the initial mode of respiratory support in critically ill, very low birth weight infants is associated with lower incidence of chronic lung disease. Short binasal prongs are effective and convenient patient device interfaces for delivery of CPAP in newborn infants with respiratory distress. Bubble nasal CPAP represents the simplest form of CPAP that may offer physiological advantage over other CPAP systems because of its effective lung volume recruitment and efficient gas exchange in the presence of low lung compliance. Use of correct CPAP devices, attention to details during CPAP delivery, and bedside caregiver experience are the key to nasal CPAP success. And I have some Columbia experience. So now if you look at the data on this slide, this tells you the CPAP experience with increasing post-menstrual age. I'll show you the same data. So if you look at with the increasing gestational age, post-menstrual age from 23 weeks to 34, that's what this data shows. And what it shows is over 28 weeks, you can start almost all babies on CPAP. Sorry. Almost all babies can be started with CPAP. And it's successful in almost all the babies. You can see the success rate at Columbia over 7 weeks is in high 90s. Even when you look at babies less than 28 weeks, as low as 23 weeks, CPAP can be started in as low as about 50%, and it is successful in half of them. There is another issue, how do you define it will be success? But I think for now, as everyone is working towards that, we have to keep in mind that unless you try, you would not know. In our institution, in the gestational post-menstrual age range is 23 to 34 range. 1/3 of infants are ventilated and 2/3 are managed with CPAP. And if you look at the same data by the weight categories, less than 800 grams, again, CPAP can be tried in significant number of infants, and it's almost successful in about, I would say, 40 to 50% of babies. Over 800 grams, it can be tried in almost all babies. Our overall CPAP success rate ranges between high 70s to 80s. There are other institutions who have similar result. Hani Ali is close to 75%, and many people who practice same. So I think the major issue comes is how to figure out which baby, and we've tried to do that. And I can share that, but let me see if I can take more questions.
Hi, Dr. Rakesh. First of all, thanks for the very nice lecture. I'm Dr. Wung, just on that same slide, going to the tiny babies because 8 and 9, when you say success rate, does that mean these babies do not require mechanical ventilation or intubation?
You know, there is a lot of flow, so it's very hard to comprehend the question. Maybe somebody can speak that a little slowly. And the mic which we were using earlier was much better.
Rakesh.
That's much better. Rajiv, your voice is, can you repeat the question, please?
So the question asked by Dr. Mudit was, he wants to define if success rate means that it is totally not ventilated at all, or at some point in time in the first 2 weeks there was a need for assisted ventilation.
I think we published this and many others have that if CPAP in the management of acute RDS, if it's going to fail, the failure will happen in the first 24 to 48 hours. And it's early failure. And the data which I just shared with you was up to 72. And our criteria for failure are very similar to what I mentioned in my recommendation. So most failures, if you're using it for acute RDS, happen in the first 48 hours.
Yeah, sure. I can.
The other thing I want to ask is, I mean, there's enough data that surfactant below 28 weeks is very effective, and there's no doubt about it, effects of randomized controlled trial. But when you, in your experience at Columbia, when you have 725 and they put the baby on the CPAP after 3 days, they fail CPAP and need mechanical ventilation, is intubated, still gives us a very more than 2 days, and we do think that will help or does it help? It's not 2 days to give surfactant rather than intubate, give surfactant and a 25-weeker, extubate early. That strategy would be better, or just putting baby on CPAP and then failing after 3 days and then trying to intubate when you know that surfactant is not going to be very effective.
Want to speak with Rajiv?
Can you just repeat it, please?
This Mudit's question was, it's a very nice question, in fact. In fact, reflects Martin Kessler's some statements in some journals. Almost 2/3 of is a blanket statement. In 2/3 of these babies below 750 grams eventually land upon a ventilator. So that was the blanket statement Martin used long time back. Mudit is extending the question, saying that you have to use CPAP initially, give surfactant, and you fail after 2 days, go back to mechanical ventilation, or you ventilate, come off CPAP, and come off the ventilator, and put on CPAP. Second one. The third thing is, after 72 hours, is there any requirement to give surfactant at all if you put him on assisted ventilation?
So I'll start off this. Sorry, I don't have those set of slides. There's very nice old data where they looked at 25 to 29 weekers. They compared them with surfactant sufficient in term infants, and they looked at the alveolar surfactant amount in preterm infants between 25 to 29 weeks who got surfactant and who didn't get surfactant, and they looked at several time points up to, I think, about 2 weeks of age. And it's very clear that infants who get surfactant, obviously their surfactant levels match the ones at term, but the infants who don't get surfactant, by the age day 3, their alveolar surfactant or their intrinsic surfactant production then becomes more of a function of postnatal age than the postmenstrual age. So the babies can, and we all know that when we give surfactant, one dose is enough. So I think the big question comes is, can you sustain the baby during that period, and how effective? And there is a lot of data now emerging that even few mechanical breaths in the delivery room, intubation, the process of putting in a tube, that's why Lisa and MIST have been around, that all these are big components for development of chronic lung disease. So if you can expand the lung physiologically and keep it open with CPAP, there's probably nothing better, because that's what you're trying to do with the intubation. Surfactant, yes, it's a separate issue, and if the lung is not sufficient, and it's been shown that some of these babies, particularly the ones who fail, they need surfactant, and I wish we could identify these babies much earlier. In our cohort, we have looked at, and I'm showing you some of the data, which are the variables which are associated with surfactant failure, and you can see the success is in green, the failures are in blue. So if you are less than 26 weeks, you're less than 800 grams, you needed positive pressure ventilation in the delivery room, or your DO2 gradient is more than 180. I think the biggest one is the severe RDS on the initial chest X-ray. That's the baby you need to watch very closely. That's the one who's going to, if you don't have anything, and I think if you are, obviously if you're starting with a CPAP therapy initially, and that's what we recommend, I think the units should develop their own strategy. Many people start off, using this approach in first with a little bigger infants, more than 1,000. When they get good with the CPAP use, then they lower. And the results have been replicated at so many places. We've looked at this data again. Individually, if you see, we have looked at other things, like this is a different cohort, less than 1,000 grams here. And if you look at the overall incidence of chronic lung disease, it's 9.6% at Columbia. And if you look at comparable Vaughan institutes, it's more than 50%. And none of the factors such as intrapartum antibiotics, GBS, less than 26, severe RDS, individually, other than the severe RDS on X-ray, has a predictive value of 81. But when you look at the cumulative, you take severe RDS on the chest X-ray in a 26-weeker who has a bad pH of less than this, high oxygen requirement, and then you can see you can increase. I think it is, that's why I think CPAP is, particularly bubble nasal CPAP, it's not just science, it is an art. So it's a combination of science and art, and unfortunately, we cannot do a comparative trial at Columbia to show that it's superior, but I'm sure someone at some stage will be able to. So I don't think so we are there. People are trying to look at things like, looking at the gastric aspirates for lamellar bodies and basing surfactant or insure for those babies, which can be quickly done, but I don't think so we are there. The aerosolized surfactant delivered by our CPAP, we thought that was going to be great. We participated in that trial for the smaller babies. And my experience with the device which we used was not that very good, because it seemed that all the aerosol was coming out of the mouth and very minimal probably reached the baby. I haven't seen the results of that study, but I think that would be the effective way, not to touch the airway at all, and yet find a way of delivering CPAP, the surfactant. So I'm pretty sure we will see. We've come a long way, and we will see that soon.
One component of his question was that the baby, you said most of them fail in the first 24 to 48 hours. If in case they fail after 48 hours, do you still give them surfactant?
I think if they get tube, that's my personal own bias. If they get tube and they have their, they obviously, then they're failing in our place, they're on 60%. Yes, then we would give them quick doses. We don't extubate them right away, but our focus is to get the tube out in the next 24 hours. So brief ventilation. And we've seen in our data set too, by doing that, you do not increase any morbidity. And you've seen what I showed you about the recommendation of surfactant replacement from the Committee of Fetus and Newborn.
Hi, Dr. Rakesh. My name is Dr. Anubhav. I'm a neonatologist. Are you able to hear me?
You look like Jitendra walking. I've tried to saw you. Have you seen his outfit like Jitendra in the 60s?
Hi, Dr. Rakesh.
This is much better, yes.
Yeah. Okay. I mean, it's a wonderful presentation. I believe you cleared so many things, so many questions are answered really. My concern is, you know, the success of CPAP, as you are already mentioned, it is the skill really, and the interface. If it is not chosen appropriately, you eventually fail. This is what we have seen, and the entire team has to be geared for that. And usually, you sort so many modalities of giving CPAP. Is it? Have you concerned about the nasopharyngeal CPAPs? You know, at the delivery room, it is mostly easier. People put nasopharyngeal and then bring to the unit, and then you start a you know, positive CPAP in a proper setting and a proper system. Really, have you ever tried nasopharyngeal CPAP?
We haven't done that, and the reason I can tell you why. Number one, Columbia is unique that we have a resuscitation. We have a small NICU in the delivery room, so all our admissions, preterm, non-preterm, cardiac, we take care of all of them. All those admissions are in that area, and literally it takes us 3 to 5 seconds to bring the baby into that area. It's a very controlled, so the baby goes on CPAP within 5 minutes. So we are set up to start nasal CPAP right away. The reason I wouldn't recommend using the pharyngeal CPAP, if you look at the resistance is directly proportional to the length of the device and inversely proportional to the square of radius. So that's why the short binasal prongs, and I think there's a Cochrane review on that too, binasal prongs are much superior. But putting this question, putting all this in the context you asked, I think the one, yes, I can't agree with you more. It is a complete team approach. Physicians can buy it. If the nurses and RTs don't buy it, it's not going to work. The whole team, because the people who are at the bedside 24/7 are the ones who have to implement it and have to buy it. And I leave it to the teams. You know, you find what works in your system and then just stick to it. And if you feel that because of the proximity or how you're resuscitating, you can do quick pharyngeal CPAP in the delivery room and convert to, if that works for you, and so long as you're not touching the airway, you're getting plus points. And as you get better with your implementation of binasal prongs, you can be, see what's happening is, I mean, we all know now, if you look at the algorithm for resuscitation or targeting oxygen, even the NRP is saying, you know, at 1 minute, oxygen saturation should be in this range, 2 minutes, it should be slightly over. So if most people, when it comes to practice, we know in utero saturation is about 67%. The next number any caretaker wants to see is 100, without forgetting that, you know, there is numbers which come between 67 and 100. And I personally believe when you do that with the use of CPAP, you're expanding the lung more physiologically, causing less barotrauma. Whether you can achieve that with nasopharyngeal tube, we haven't looked at it, and the reason I mentioned that we have a setup right in the delivery room, so we start CPAP within 3 to 5 minutes of birth. So, and that can be done, and I can share with you how we transport babies from that area. We transport babies on blended oxygen. So we are not giving, most of our babies, you won't believe, and this is true for other places too, and perhaps this is the experience at your end too. The babies are in room air, whether you're ventilating or CPAP. And I think it's then we deal with is, in some babies, after 48 to 72 hours, we start seeing failure, and then we get into this cycle. So we don't see much of that with the early use of CPAP.
And use of surfactant, as the question was asked before, I mean, to use surfactant later, like after 72 hours or say fourth day, if the baby is reintubated, is it a possibility, or is it going to help for the morbidities like BPTs and all this? Or
Most of the, sorry, complete the question, sorry.
and the doses of surfactant, how much you should recommend? Because sometimes we see when the babies are not improving, people use multiple doses of surfactants, like 3 to 4 doses, which we don't see a reality, but you know, in practice, people do it. What should be your opinion on that?
So, you know, the surfactant use, I would say if you look up which particular group of babies who need surfactant, and these are essentially your less than 1,000-gram babies who get surfactant. And then surfactant volume is an issue. And I don't know what's available in UAE and other countries, but in United States, of the surfactant available, the most concentrated form of surfactant is Curacao. And if we are going to give, we will give a full dose of 200 milligram per kilogram, is 2.5 ml, and to the baby. And usually, we all know that in infants, the surfactant metabolism is 90% of the surfactant is recycled. So if you give one dose, that's why most of the places babies only receive one dose. That surfactant stays for a long time. It's recirculated and all. And if you're giving multiple doses and it's not effective, it wasn't working in the first place. And the management, the need for surfactant, going to the first part of the question, during the acute phase, and I said most of the failures happen in the first 48 hours. Failures which happen later on have multifactorial causes, and surfactant deficiency could be one. And you need to figure out what's the underlying cause. If there is oxygen need and all, surfactant can be attempted. But I think many of those babies, if they're failing late, one has to, and when this is still a controversial area, the FDA does not approve or the use of inhaled nitric oxide in preterm infants. But what we would do if a baby is failing at 48 to 72 hours, we would get an echocardiogram, look for signs of pulmonary hypertension, and depending on what we find, we will accordingly manage the baby.
And have you ever tried LMA surfactant?
No, we haven't done, but I know the studies have been done. The data is much more stronger with the current technique. The Australian technique and the Germans, they do with the catheter, 17 gauge catheter. And I was recently at a conference in India, there I saw this a new catheter which the Dutch have, and you can bend that catheter a little bit for better. But LMA has been done, but I think your delivery, what you want to do is do an intratracheal delivery, and I don't think so it's as affected with the LMA compared to LISA.
Thank you so much. Thank you.
I have one question on high flow. I could see you're not a fan, but do you have it in your unit at all? And when you wean CPAP, if the baby fails, do you put them on high flow instead?
We have 25 neonatologists, and 24 of them follow the CPAP weaning as I showed you. No, they don't go with the hypo. And the one person who is converting now, he was a big proponent of, speaks worldwide, very well known. And I think I'll be very cautious. Now, if you look at the high flow nasal cannula data coming from the major group in the hipster trial and all those trials, especially there may be some room in if we can define that baby, but in our hands, we are better off getting the baby off respiratory support with CPAP than with high flow nasal cannula. It has its plus points with developmental care and also, but it prolongs the area. And I'm concerned there is data on increased morbidities when high flow is used to wean babies off
Thank you.
and
And
longer stays.
regarding NIPPV, I mean, Professor Ramanathan feels NIPPV works better than CPAP, but you feel bubble CPAP is better, I think.
Ram is a very good friend. I love him, but I don't like his cannula, and I told you the reason why. And you know, there is a lot of us in US who feel the same. It's very convenient to use. It's whether do you know the pressures you're generating, and if you know, our incidence of BPD is 6 to 7%, and it's true as of 2018. You tell me anything which will bring my CPAP, my BPD rate to less than 5%, I will follow it blindly. Don't talk to me if your BPD rate is 60% and you are bringing it down to 55%. Means if you can help me to bring my BPD rate below 7-8%, I would love to follow that therapy. Until then, I just want to continue what I do.
Good evening from here. I think it's a good afternoon for you. I am Dr. Karthikeyan, consultant neonatologist in Dubai. I am practicing a MIST ever since I joined Dubai as a neonatologist. It is interesting to note that this new BPD with these new X-ray changes were diagnosed. Now, when I read about MIST, when I was doing MIST, it's interesting that when you use this 0.3 FiO2 or 0.35 FiO2 cutoff and give surfactant without violating the airway by Lisa technique, the X-ray changes itself are obliterated. Like we don't get that tradition, the classical features of RDS, although if it left to its own, following the previous cutoff, intubation and all, you would have got the classical features of X-ray. So now there is the definition of RDS is not by X-ray alone, it's by the clinical features, retractions, FiO2 requirement, like that it says. In a preterm baby with retractions, we can define RDS even without the classical X-ray. That's number one. That's interesting to me. Another thing is stochastic resonancy in bubble CPAP. Now studies have come, it says that the noise levels of bubble CPAP are much huger. They are nuisance to the baby. And so I think I read one study, I don't know how powerful was it. They say this noise has adverse effect on their neurodevelopmental outcome, at least in the short term. Counters.
Yeah, I think this concept means the people have shown most of the stochastic resonance data in vitro model. In vivo means I can tell you from my clinical experience, when you have a lot of water, when you're running the circuits wet, and there are some water droplets in the circuit, and you can see those the oscillations being transmitted, something very like what you see on high frequency oscillation. Whether the gas exchange mechanism differ, whether when you use bubble CPAP versus other forms of CPAP, there is more data coming out on the angulation of the Draeger just came out with a bubbler, which has an angle at the end. You still immerse the same amount, but instead of being a straight tube, it's a curved tube, and they're showing that there is more oscillations and all. Whether these oscillations convert into, I don't think so, it has been studied well enough to say that they are effective in decreasing the incidence of BPD. But certainly, from what you said in the beginning of your when you were talking, just keeping the airway protected, but not giving mechanical breaths and avoiding injury up front, you are probably not seeing those changes on X-ray that were classical in the past. That's what I would say. I think the stochastic resonance has been used in other areas. It's a big hot thing in adult neurology, where there is nerve damage and how you do action potentials besides the damaged nerve, and you're able to recover that damaged nerve. So it has a role. It's never been evaluated in a big way from the point of view whether it affects BPD in the positive or negative way.
The noise levels, I measured the noise levels using this cell phone dB meter. It was 80 dB with bubble CPAP. Good or bad? I think your long-term outcome also. One study I can quote for you. Noise levels with bubble CPAP. It is 80 dB. I calculated using my cell phone.
And then it also depends where your bottle, where your bubbler is. Most of these babies are sick and they are in the isolate. So whether that 80 dB reaches the baby, I'm not sure. So certainly when we use devices, when the oscillation uses high frequency oscillatory ventilation, the noise levels are, I don't know the exact dB levels, but those are all approved. And I think one of the contexts is that whatever those noise levels are, they are not reaching the baby in an isolate.
Dr. Jayashila, neonatologist. I just want to ask you one thing. Have you ever used nasal masks? Like all your slides, you were discussing about nasal prongs. So in Colombia, do you at all use nasal masks?
So if you are unfortunate that you get a septal injury, or if you get a baby from an outside hospital, which is very common, that there is a big septal injury. So those are the scenarios where we would use a nasal mask. But in small babies, it's all binasal prongs. If the septum gets damaged and you don't want to intubate the baby, because we do nasal intubations too, all our intubations are nasal. So a septal damage is also, if we can't, baby needs to be intubated, it will be an oral intubation. If we can get away with CPAP, we would do mask CPAP.
Another question, are there any studies comparing, you're talking that now the bubble CPAP is working almost like that of HFOV? High frequency.
Sorry?
In one of
I've heard about it, people talking about it. It is where HFOV with the mask is an effective way of removing CO2. That's been shown, but whether it means anything from the short-term BPD, I'm still waiting for the data.
So at present now there are no nothing towards supporting. Now that nasal, some of the new ventilators are coming with nasal HFOV facility. Any studies comparing the CPAP with nasal HFOV?
No, not that I'm aware of. Now, my good friend, Indian friend Mukherjee talks a lot from, he's at Toronto. They are the ones who are pioneers in doing nasal HFOV. I'm yet to see any study showing outcome data on comparative on CPAP versus, again, this is something relatively new. And as I said, means we would like to see studies which show, you can decrease the CPAP in our case from 8–9% to lower than that. I would then definitely look at it. But as for the literature is concerned, I don't think so there is data out there comparing CPAP versus HFOV. You have to keep in mind when people do the studies, they have to be good at doing both the things. You can't compare ventilation with CPAP if you are very good at doing ventilation and not so good at CPAP, or vice versa. If you practice all this, all your patients are going to say, I love my CPAP. Thank you for your patience. I will take questions, and I have my email address up here. If there are any questions related to CPAP or elsewhere, I could be of any help to anyone who is taking care of babies all over the world. I'll be glad to help.
Rakesh, that was a very fantastic and very informative lecture. In fact, I must use the word fantastic because even after practicing for 30 years, I still found a few points extremely important. And I will ask you all those deadly questions after my faculty ask you questions. So be prepared then for a small display of very potentially dangerous questions. Hand over to Dr. Mahmood.
There is a little bit of echo, but I'll try my best to hear the questions.